Okay, so good morning or good day, depending when you're listening to this. I'm Caroline Miller or Caroline Kirkland on the Inner Circle, and I'm a consultant up in Scotland in metabolic medicine. So this morning we are going to chat about coronary heart disease specifically. So last week we had a review of cardiovascular disease, which includes the heart attacks, includes the brain, strokes, and peripheral vascular disease affects your legs. But this morning we're going to kind of hone a little bit more in on coronary heart disease. Okay, so I'm going to share my screen because we're going to have a little look at the heart. Okay, so I showed this last week. If anybody can give me a nod and let me know if they can see that.
Yeah.
Good, excellent. Right, so it's a muscle. Okay, it's about the size. I always tell my patients your heart is about the size of a fist. Okay. And it pumps blood around your body. Between 60 to 100 beats per minute is deemed normal. Okay, so everybody's beats normally about 70 to 80 beats per minute. Okay, if you exercise a lot, you will obviously know that your resting heart rate can go down. If you're exercising, your heart rate will go up. Okay, but on average, say if it's between 60 and 100, if we take 80, that's 80 beats a minute. And if you're 80 years of age, I haven't done the maths, but that's a lot of pumps, a lot of beats. Okay, so it's a phenomenal organ. Okay, the blood comes, leaves the right-hand side of the heart. So the heart has got 4 chambers, 2 atria, left and right atria, and 2 ventricles, left and right ventricles. And the right ventricle, essentially blood from the body drains back into the right atrium, goes into the right ventricle. It then pumps from the right ventricle up into the lungs, where it is oxygenated, and then it comes back into the left atria, the left-hand side of the heart. And it's the left ventricle is the big chamber that has to pump it around the rest of the body up into the aorta, which is this big artery here. Okay. And it is supplied by 3 coronary arteries that wrap around the heart. Okay, so the heart itself is pumping blood around, or forces the blood out of the heart and pumps it around the rest of the body. But as it's an active muscle, it also needs a blood supply. So it's got 3 coronary arteries that wrap around it and actually supply oxygen and blood to your heart. Okay, so let's stop that because I don't like looking at pictures of the heart all morning. All right. Right. So symptoms of coronary heart disease. Plenty of you will probably know a bit about this because you may have a friend or a relative that has heart disease. So what kind of symptoms do you get when you've got problems with your heart?
Breathlessness.
Breathlessness. Yep. Okay, so essentially, if your heart is under more strain, you will become breathless. And this may be more obvious on exertion. So I'll ask patients, any issues with shortness of breath going up a flight of stairs. Okay, now everybody will have a bit of shortness of breath going up a flight of stairs because me walking along a corridor versus me going up a set of stairs is working my heart harder. But it's kind of a change in, your breathing. So breathlessness is one. Yeah.
Pain?
Swelling in feet?
Yep, swelling in your feet. We'll come back to that. Somebody else said pain. Okay, so yeah, pain's a big one. All right. Does anybody know what the pain is the chest pain's called when it's related to your heart? There's a
Angina.
Angina. Excellent. Okay, so angina is the medical term for chest pain related to your heart. Okay. And the angina can be referred to as stable or unstable. And I had several patients in yesterday. I was chatting to a couple of them, and both of them had what we call stable angina. And by stable, we mean the pain doesn't come on unless you are exerting yourself. So when you're sitting watching telly or you're lying in bed, you don't have chest pain. But it's if you go up a flight of stairs or you're walking along the flat and you're fine, but then all of a sudden there's a gradual uphill. And that it comes on with movement or exertional activity, and that's stable angina. When the disease progresses, it can become unstable angina, and that's when it gets very serious because it can come on when you're in bed or at rest watching the telly. Okay. Does anybody have any idea what the pain's like? What's it described like? Is it a sharp pain?
My mum described it as an ache.
Yeah, it's dull. It's not a sharp pain, and that's
yeah.
one of the things that you'll get asked if you ever come into A&E, or your GP will ask you what type the pain is. So is it sharp or dull? And it's more likely to be dull. Okay, a sharp pain in the chest may be a musculoskeletal thing. You know, you've pulled something, too many press ups, I would suggest. Or you know, you've lifted something heavy, or indeed you might have a sharper pain would possibly be reflux. And there are 2 or 3 things that are really quite difficult to differentiate. But angina will be a dull pain, a dull ache, and a heart attack per se is supposed to be really quite horrific. Lots of people will describe it as a sense of impending doom. It's like an elephant sitting in your chest when you're having a full-blown heart attack. Okay, so it sounds pretty grim. Okay, I've obviously seen people have them, or should I say they've come into A&E, and they you know, they're not looking too good. So on that note, so you've got pain. You can also get pain elsewhere, not just in your chest.
In your arms.
Left arm.
Yeah, which arm? Your left arm. Yeah.
Left.
And this is one of the things I really loved learning things like this in medical school. I don't know, they just tickled me. So basically you can get left arm or left jaw pain, and that's essentially because the nerves from your left arm and your jaw go into your spinal cord around about the same level as the nerves from your heart, and your brain doesn't know which is which. So you don't have arm pain as in you haven't hurt your arm at all. It's just your brain can't tell whether the pain's coming from an issue with your heart or with your left arm or your left side, and that's why it's left-sided. So right-sided arm pain is not associated with your heart. Okay, so that can be quite a good differentiator as well. Okay, so we've got shortness of breath, we've got pain, whether it be chest pain or whether it be left arm, left jaw pain. Any other things?
Can't walk very far.
Yep, you can't walk very far, but I'm
legs.
just thinking of kind of the symptoms you get when you're actually having either angina
Sweaty.
or sweaty. Yeah, okay. So you can be sweaty, and if you ever see anybody in the midst of this sweaty, pale, okay, they look grey, they don't look good. Okay, and sick, nauseous. Okay, they may actually vomit, or they may just feel sick. So lots of things we will ask, well, were you sick? Did you feel nauseous? Were you sweating? We ask about palpitations as well. You may be short of breath, but you may feel your heart racing. So that's another thing. Okay, you can have a heart attack and it can be silent. You can have none of the above. And that does happen to people. And sometimes you find that out when somebody comes in and gets a heart tracing done for whatever reason, and they'll say, oh, you've had a heart attack because your ECG has changed, or they get other tests done like an echo, a scan of their heart, and you can see part of their heart wall muscle isn't working. And they've obviously had a heart attack at some stage and they haven't known about it. Members of the population who have an increased risk of having a silent MI are older people and people with diabetes. And that's because diabetes affects your nerves. So you just don't get the pain, you don't get the sensation. But you may get the shortness of breath and whatever and feeling sick, but you won't get the pain. Okay, so those are basically the main symptoms of coronary heart disease and to look out for. In terms of what you should do if that ever happens, we call it worsening advice. So if I have someone who's, and definitely someone, I spoke to 2 patients yesterday who currently have angina, they're being reviewed by the cardiologists and they're, you know, getting investigations and hopefully further procedures, but you know, that takes time. So my worsening advice is always, lots of people with angina will have a spray. It's called a GTN spray, glycerol trinitrate. Okay, and that sprays under the tongue and it results in dilation of your arteries and veins. Okay, and it dilates your arteries around your heart, so your heart gets more blood into it. Okay, if they have stable angina, chest pain comes on, they take the spray and the pain goes away in 10 minutes, that's fine. You just kind of record or keep an eye on how often you're doing that, because obviously the more frequently you're doing that, obviously you're having more and more issues. But if you have chest pain that lasts for more than 10 or 15 minutes and it's not relieved by your spray, or it's the first time you've had chest pain and it goes on for longer than 10 or 15 minutes, you have to go to A&E. Okay, you have to present in an emergency department, just to make sure that if something is going on, that you can get seen and reviewed. Okay, so causes of coronary heart disease. What causes coronary heart disease?
High cholesterol.
High cholesterol. So what does the cholesterol do?
Clogs your arteries.
Blinds your arteries.
It does, blocks your arteries. And what, can anybody remember the name, the fancy medical name for the process? It's quite a mouthful.
Atherosclerosis.
Excellent, yeah, atherosclerosis. Okay, so and atherosclerosis essentially just refers to the buildup of fatty plaques or fatty substances in the coronary arteries. Okay, so I shall now see if I can get this up. Okay, right. Let's share again. Share the screen. Okay. This is an example of plaque formation, just a cartoon. Everybody see that?
Yeah.
Yep, good. Right. So healthy artery, whistle clean. So this is a basically just cut through it. And your arteries are essentially, I like to describe them as hose pipes. All right. They're like hose pipes. They just carry blood from A to B. And this is a healthy artery without any fatty plaques. Little red dots are red blood cells, and they're just tootling along happy, no issues. You then get some plaque formation, so you get cholesterol or fatty deposits laid down. This happens quite early in life, especially in the Western world. Okay, and you can see here the blood now has to go up and over the fatty plaque or the speed bump. All right, these can happen on both sides. All right, so you get plaque formation on. It just doesn't happen on one side of it. It can happen in the whole circumference of your artery, and this becomes more and more narrow now. Theoretically, I think when this gets to 70% blockage, that's when you'll definitely have angina. Okay, you should get symptoms when you get to 70%. All right, and a couple of different things can happen here. You can either get a clot, or over these fatty plaques is usually got like a thin calcium cap that's very kind of fragile. And that can either break off and rupture, or you can just actually get a blockage. And that's essentially what happens when you have a heart attack. All right, that's what's happening. There's a blockage in one of your arteries. Okay. So essentially, atherosclerosis is just a fancy term for the furring up of your arteries with fatty plaques. Okay. And the fatty plaques are called atheroma. And it essentially just restricts the blood supply. So if you have the test that they do is a CTCA, which is a CT coronary angiography, okay, and that's essentially putting dye around to have a look at the fatty plaques, okay, and you can see with the fatty plaques the kind of blockage you have and how well the dye flows through. And obviously, if you get quite a significant blockage, at rest you may be okay, but as soon as you start to exercise, walk up a set of stairs or walk quite fast, your heart requires more blood, as does the rest of your body, your muscles and your arms and your legs and things like that. And that's when your heart's put under more strain, and that's when you get angina. Okay, and again, it can be asymptomatic to begin with. There will be quite a few of us with fatty plaques. I think they get laid down quite early in the Western world, as early as your 20s. And it can lead to heart attack, or obviously if it's in your head, a stroke. Okay, and the process won't just be, if it's happening in your heart, it won't just be happening in your heart, it'll be happening possibly in the rest of your body. And there are a certain subset of people who can have had a heart attack and a stroke and peripheral vascular disease, and these patients are labeled as being arteriopaths, okay, because it's affected their whole body. All right. Okay, any questions about that?
I have a question, if that's okay. Sorry,
Yep,
I'm not
sure.
on video. I'm getting ready for work.
Okay, yep.
And walking to work.
Is that Isabel?
It is, yes. Sorry.
Yeah, no, it's okay. Your box has gone yellow, which is quite good. It means I know who's chatting.
Okay. I've just been diagnosed with high cholesterol, and I was thinking of plant stanins instead of statins. Is that a dangerous thing to do? Should I just go straight onto statins? I mean,
I can't give any individual advice.
Okay.
To patients. Okay. This is my indemnity, only covers me for education. Okay. What I can say generally is the statins are probably the most trialed drug we use, bar none. Okay. There have been plenty of randomized controlled trials, and then they've all been brought together in studies. I think there's been over 170,000 patient results looked at on statins. Okay. I don't actually chat about statins per se in this set of talks, but statins, for anybody who's unaware, reduce your cholesterol. Okay, they reduce your LDL cholesterol, and don't worry, I'm going to do a session on cholesterol, but they reduce your LDL, your bad cholesterol. Okay, and we do have the evidence base that shows that they reduce morbidity and mortality when it comes to heart disease and stroke. Okay, but sorry, Isabel, I can't give independent medical advice.
Completely.
All right, but yeah, statins are probably the most trial drug that we use, and there are actually, because we know that LDL decreases morbidity and mortality, we've now developed 3 or 4 more drugs, including monoclonal antibodies and injectable therapy that will reduce your LDL, because we know it's really important to reduce that in terms of reducing your morbidity and mortality. Okay. So yeah, that's important. So in terms of the fatty plaques, essentially what happens is they are hard, or they become hardened. It's uneven. That together with high blood pressure results in quite turbulent flow, and that results in an increased risk of blood clots as well. Okay, so as well as the plaque rupturing and causing a blockage, you can also get turbulent flow with high blood pressure, and the fact that the fatty plaques, you don't have a smooth artery wall anymore, and that can result in the clotting cascade and getting a blood clot. Okay. The clots can also break away and get lodged elsewhere, so they could get lodged in your head and cause a stroke. Okay, so we're now going to move on to causes of coronary heart disease.
Being overweight.
Being overweight, right? So excellent. What does being overweight do? Why does that?
You have an
Pain on
increase
the heart.
in fat, and the increase in fat can cause because you gain weight and you're causing more pressure on your body.
Yeah, so essentially there's quite a few things, and we can kind of tease this apart. So if you're overweight, okay, you are more likely to have a diet higher in saturated fat, I would argue, or at least refined carbohydrate. And the refined carbohydrate, any excess carbohydrate gets converted to triglycerides, and don't worry, we'll have a chat about this later on. So that alters how your liver processes your cholesterol and your triglycerides. Okay, so if you're overweight, you're more likely to have higher cholesterol, and you're more likely to have a higher LDL cholesterol. Okay, which is the essentially the fat that results in the fatty plaques. The LDL cholesterol is the one that is oxidized, taken up by macrophages and laid down to form the fatty plaques, and we'll do a session on that. Okay, so if you're overweight, you're also likely to have high blood pressure. Okay, and high blood pressure results in more turbulent blood flow, and then the more turbulent the blood flow that has to scoot over your fatty plaques can result in either rupture of the fatty plaque, or, as I've previously described, a blood clot. Okay, so higher weight, higher blood pressure. Anything else to do with high weight that can increase your risk of coronary heart disease? Diabetes, excellent. Yeah, that's a really, really big one. Okay, so if you're overweight and you've in particular have got what we call truncal weight around your abdomen, you have an increased risk of insulin resistance, and as that develops further, you then get an increased risk of becoming a type 2 diabetic, and we know that diabetes increases your cardiovascular risk. Okay, so weight increases your chances of having a fatty liver, having a higher cholesterol, having high blood pressure, and diabetes. So it's all linked. Okay, but that's quite good, because that means if you tackle your weight, you're tackling all of those. All right, so that's kind of turning it on its head. All right, A couple of other things that are really important. There's one really, really important thing that I usually get on my soapbox about, if you've listened to me before.
Smoking.
Yes, smoking. Okay. Smoking, and everybody knows that smoking can result in lung cancer. That was shown many, many years ago. But I think there's a lot of people don't get the link between smoking and heart disease. Smoking essentially accelerates the process of the fatty plaques getting laid down. Okay. So if there's one thing I can get any of my patients to do in terms of heart disease or reducing the risk, smoking's number one, even before weight loss. Okay. Smoking is a no-no when it comes to coronary heart disease. All right. And alcohol as well. Excess alcohol. Excess alcohol can make your heart very floppy. You can get a cardiomyopathy from drinking a lot. All right. And alcohol will also affect your liver, and in turn that will affect your metabolism of your cholesterol and your triglycerides, the two fats in your blood. Okay, so those are the big ones. Right. Diagnosis. Going to your GP if you've got issues. All right. Essentially, family history is really important. Why is family history really important?
Some of it's genetic.
Yeah, there's you can have a genetic predisposition to having heart disease, so it's really important. And one of the things we ask about in clinic, and I get lots of referrals from GPs, if people have a high cholesterol and have a family history of heart disease, it's really important to tease that apart. And again, I'll come back to that when I do the session on cholesterol. So there is a condition called familial hypercholesterolemia, or FH for short, because that's obviously a bit of a mouthful. So familial is just in the family, and hypercholesterolemia is just high cholesterol. Okay, and it's the most common genetic condition in the UK and Europe. The prevalence is thought to be 1 in 200. All right, and about 10, 12 years ago, when I was a junior doctor, we were actually quite good at finding them in Scotland, and we've really slowed down now. We have meetings every year with the genetics lab up in Aberdeen that does all our diagnosis of FH for us, or it looks at the genes that are involved, and we really can't find people anymore. It's getting more and more difficult. And I think a lot of it is being muddied by lifestyle. So if I have a patient that's been referred with a high total cholesterol and a high LDL by the GP, and they're asking, you know, does this patient have FH? Do they need to get genetic testing? If the patient has got a normal or a healthy BMI between 20 and 25, and they've had a high cholesterol since they were young, and they've got a good going family history, and I'll come back to that, they've got a, you know, the chances are I will find somebody with FH. But the problem is I got lots of referrals now. The ladies, they're all over 50, and we know your cholesterol goes up round about your menopause or just after your menopause, or around about that time, about 50. Unfortunately, they haven't had a cholesterol done 20 years ago, so I've got nothing to compare it to. They're also overweight, and they may have a family history of heart disease, but if I go into that in more detail, you'll find out that yes, their father had a heart attack when he was in his 50s, but he was also overweight, smoked, and drank a lot. We tend to have all three in Scotland. We like to do things well. Okay, and I came from Northern Ireland, Belfast, which is basically the second heart attack city of the world, I think, after Glasgow. So it is quite difficult, but it's something that you should be aware of. Okay, so the things you need to think of are, have you got a second degree relative that has had a heart attack or a stroke under the age of 50? And by second degree, that is, first degree are your siblings, your brothers, sisters, your mum and dad. Second degree is your grandparents. Okay. And then if you have a first degree relative with heart disease under the age of 60. Okay, that's important. And then there are other things you have to think of in terms of your cholesterol. So you want a total cholesterol more than 7.5 and an LDL cholesterol more than 4.9. But don't worry, we'll come back to this when we do about cholesterol. But family history is really important, okay, in terms of determining whether you have a genetic predisposition to heart disease. Now, There are quite a few people we test and they've got quite a really strong family history of heart disease and they don't have familial hypercholesterolemia, or they don't at least have one of the mutations that we know about at the moment. Okay. So we then kind of put them down as having a polygenic cause of having a high cholesterol. And I think that's a bit of a cop-out. It's a bit like going to your GP and they've done every test under the sun. Then they say, yes, it's a virus. All right, we don't know what it is. It's a virus. Well, I think it's the same with kind of polygenic. There must be, but we know there must be lots of little genes that are involved in controlling your cholesterol, but you can't test for that. Okay. So there may not be an explanation, but family history is really important. If you've got problems with chest pain, try and be aware of your family history. So if your family physician asks you. Other tests that should get done, simple tests should be done. You should get your kidney function done, simple blood test, essentially because kidney disease increases your risk of heart disease. Okay. You need a lipid profile done. So your GP should be looking at your cholesterol and your triglycerides. You want your liver function done as well, just to make sure you don't have a fatty liver or any problems with your liver. HbA1c, GPs don't normally use this as a diagnostic tool. I use it in clinic, but I use it in clinic not because I'm trying to determine whether somebody's diabetic. I want to look in clinic to see whether somebody's insulin resistant. And again, we'll do a session in that in a couple of weeks' time and explain that. Blood pressure is very important. Okay, and again, we'll do a session on blood pressure. And then further tests. Up in my health board in Scotland, the GPs have an ability to refer you to the rapid access chest pain clinic. So if you come to my clinic or you go to your GP and you've got what sounds like angina, so it's pain that may come on after going up a flight of stairs, or you've noticed you've become more short of breath recently and you don't have lung disease, they can send you to the rapid access chest pain unit, and at that stage you will be asked to go on a treadmill, and you will get something called an ETT, which is an exercise tolerance test. And essentially you get all the little sticky things put on you so that they can look at your heart trace, and they put you on the treadmill and they ask you to walk, and they can strain your heart by just still getting you to walk, but they elevate the treadmill. And you can see quite dramatically how much more difficult it is for somebody to walk. And if there are any issues with their heart, or your heart's under strain and it's not coping well, the electrical impulses will change and they'll be able to see that. Okay. Further down the line, you can get like a CT, or as I said, a CT CA, which is coronary angiography. That will only happen if you're symptomatic, and it's a cardiologist usually decides whether that happens. Okay. Your GP will refer you to a cardiologist, and then the cardiologist will decide whether you need that. Okay. Because as you go through the tests and they become more invasive, there's an increased risk of side effects or complications when you're actually on the table. Okay. So that's not something you do just because you want to have a wee look. I've been asked that before by patients. They've wanted privately to have a look at their arteries and whatever, but those more invasive tests can have, there's a chance you may not get off the table if one of your coronary arteries ruptures while you're on the table. So those are only to be done if you're, symptomatic, and the chances are they're going to do some intervention. Okay. Any questions about any of that? No, you're all stunned
I
into
will
silence.
say that is what you're talking about now is exactly where my elder sister is right now.
Right now. Okay.
Right now. And on the back of all of that, I think we spoke about cholesterol a couple of weeks ago, and I told you I'd have my cholesterol done, and your face was a picture. I wish I'd had your email, because I'd have emailed it. And so I'm now on statins, but it's not familial, whatever it is, because she's had all the tests. But that's exactly where she is now. But she's the complete opposite for me. She's always been slim, always been slim, but never exercised. And I've always been the plumper one. I've got 3 sisters. I've always been the plumper one, and I'm the one that exercises every day. But
no, I know, and it's one of those things. I was actually chatting to somebody. I was chatting to one of my colleagues yesterday, and there's a paper that's come out recently, and it's to do with obesity and insulin resistance. And I got emailed, it was from another consultant, and he said, oh, you need to have a read at this. He said, it's quite hard going. It's a lot of pages. I'm actually going on annual leave tomorrow, and I'm thinking, oh, I'll probably read that when I'm away, busman's holiday and all that. But there are, and this happens a lot in medicine. I always say it's an art, not a science. There are people that come into my clinic who have a body mass index 30, 35, 40, and I do an HbA1c on them to look and see if they're insulin resistant. And 95% of them will be, but there will be some cohort of patients. I had someone in that had a BMI of 42 and their HbA1c is 32, completely normal. They're not insulin resistant in the slightest. Okay, so there are other factors, and it's the same with cholesterol. You can, and that's the, I have loads of patients who have high cholesterol and they're overweight, so it'll be related to diet and being overweight and having a fatty liver. But I also have patients who are tall, slim, and they have high cholesterol and they exercise. And I had one gentleman, it was really good actually. He decided to go vegan to see if he wasn't that keen on going on statins to begin with, and he said he would go vegan, and I saw him 9 months later and I thought, this is great. N equals 1. I heard Alex on Monday talking about N equals 5, you know, it was a case, I think it was a ketogenic study that was on like about 5 patients or something. Well, this was 1, but the guy went off vegan for 9 months and his LDL didn't budge. Okay, so that's, and if he's vegan, not taking any dairy in, let alone any you know, that's not even vegetarian, he's gone a step further. There is something else at play there. Okay, and that's what it's like. And as you said, you know, your sister's slim, she's got a higher cholesterol. There are just, you know, it is what it is. We can't explain all of it, but we know 90% of the time, if you're overweight and got truncal obesity, the chances are you will become insulin resistant at some stage and possibly get type 2 diabetes. All right, so it's kind of it's playing the odds, isn't it? It won't happen to everybody. But
mine was diagnosed by the optician.
Yeah, did they see something in the back of your eyes? Right. Yeah. Okay. Yeah. No, we get referrals. The opticians speak to the GPs, and then the GPs refer in and say, oh, they've seen such and such. And again, when I come on to cholesterol, I can show you some pictures of, you can get a corneal arcus, you can get a white ring around your cornea. Okay.
Yeah, I haven't got that. I've had all the stuff. I went to the eye clinic on Monday. Yeah, fine, all fine. But I have got high blood pressure and I have got high cholesterol, strangely.
But you're working on it because you're changing your lifestyle, yes. Which brings me on to the next thing. So treatment of coronary heart disease. So I've written down here and underlined, it cannot be cured. Okay. And loads of people ask this, especially when we do the cholesterol bit, is can we remove the fatty plaques? And up until very recently, I would have said no. I would have said all the medication we put you on just basically stops them or puts them into a stage that they're not progressing anymore. Okay. However, the most up-to-date evidence, and there's still not lots of it, but there is some evidence to suggest that some of the treatments, and in particular, I think the studies coming out are if you've had a heart attack or a stroke, and then they give you medication, i.e. statins or the other medications we now have to drive the LDL down as low as possible, we can actually look at plaque regression. There are studies coming out showing that now. Okay, but that's still in its infancy. We don't have loads of evidence for that. Okay, but it's something that I will definitely read up on at some stage and possibly do a session on. Okay, but so it can't necessarily be cured, but it can be, the progression of your fatty plaques can be arrested. Okay, or slowed down. And we can have treatment to manage the symptoms and reduce our risk of having a heart attack or stroke. So how do we do this?
Diet.
Yeah, so we want to change our lifestyle, don't we?
Lifestyle, yeah.
Okay, so lifestyle is a huge thing. So what do we want to do lifestyle-wise?
Eat healthy.
Eat unsaturated fats.
Yeah, so change your diet, and if you have put yourself into a calorie deficit, you will automatically reduce your saturated fat, for the simple reason that and everybody laughs at me, I always chat about cheese, okay, because when I started TSD and I weighed out my first 20 grams of cheddar, I nearly choked, literally and metaphorically, because 20 grams of cheddar is tiny. And I kind of thought, A, I've never eaten 20 grams of cheddar in my life in one go. And B, I'm not prepared to eat it now because quote, you don't get a lot of bang for your buck. Okay. So if you're in a calorie deficit or you're watching your calories, you won't eat a lot of saturated fat because you won't be able to eat a lot of food because saturated fat is calorific. What else can you do nutrition wise?
Eat brown. and
Yeah.
eat brown
Unrefined foods.
Yes. So
eat brown.
So less processed or unrefined foods, and eat brown, not white, and eat the rainbow. All right. So if you stick to the few rules, if you eat the rainbow, you have to be eating lots of fruit and veg. Okay. Veg are not calorie dense, so you can eat a lot more veg, which helps with filling you up and satiation. It also gets all your vitamins and minerals in. The more refined something is, so the more white it is, white bread versus brown bread, the more easily it gets converted into, absorbed and converted into triglycerides as soon as we've replenished our glucose stores and things like that. Okay, so we want to change our nutrition. As a result of that, we should lose weight. We also want to exercise regularly. Why do we want to exercise regularly?
Bone density.
Lose weight.
Yep, so exercise will help you lose weight. Right, Jackie, how does exercise help you lose weight?
How does it build muscle resistance training
And
raise
what
the
does
metabolism?
Yeah, so if you do your resistance training, it lets you sneak away a couple more calories, doesn't it? Okay.
Yeah.
Because you're more metabolically active. Your exercise, whether it be resistance training or walking or running or cycling or swimming or whatever you do, also works your heart and lungs, doesn't it? It's a workout for your heart. And you only literally have to go up a hill, and it doesn't even have to be a very steep hill, and you will notice very, very quickly that your heart works harder. Okay.
Yep.
So hill walking is very good. Exercise also combats insulin resistance. Okay, because it allows glucose into your cells, and again, we'll do that. And the other lifestyle change I have here and underlined is stop smoking. All right, and again, we'll do a session on alcohol and smoking later on, but smoking, that's a big thing. Essentially, if you get what you call a coronary artery bypass graft, and I spoke to a young fella yesterday who'd had one of those 2 or 3 years ago. So that's essentially where they can't put stents in for whatever reason. It might be because you've got diffuse disease. So if you have an area in your artery that's kind of furred up or getting furred up, and the cardiologists decide that that's causing an issue, they can put a stent in. So a stent is essentially where it's like the inside of a big barrel, a coiled spring that they put in, and it opens up and it squishes the plaque and allows the blood to flow through. And the stents and everything are very fancy these days. They're drug-eluting, so I think they release drugs that keep the blood, thin and flowing along. But some patients can't get that, and I think it's because they've got kind of disease right along their artery. So, and you can't put a huge, massive, big stent in, you can only put small ones in. So they get what you call a coronary artery bypass graft. So essentially what they do is they take a vein, most commonly from your leg, and it's literally like a bypass in a motorway. So the bit that's blocked, they will put the vein from one part of the artery that's not blocked, bypass the blocked bit and tie it back on. Now, if you continue to smoke after you've had that done, you're just going to fur up really quickly the bypass. Okay, so you're just going to create the same problem. So smoking is a no-no. Medications that are important, statins as a first line, I would suggest. And then antihypertensives. Antihypertensives are just blood pressure medication. And blood pressure medication, when you lose weight, the chances are you may get your blood pressure medication reduced, or you won't, or changed, or you won't need as much of it. You might get the dose reduced. But that should all be physician-led. You shouldn't stop your blood pressure medication unless you've discussed it with your family doctor, okay? Because that's really important. It may be something you can come off, but wee bit different with your cholesterol. If your cholesterol, and again, this is very patient dependent. lots of people, I've explained about the gentleman who was vegan for 9 months and his LDL didn't change. I've got other patients who go away, lose weight and change their diet, and their LDL does come down quite a bit. So obviously their LDL was driven quite a bit by diet. And I will also always give the patient that opportunity to go away for 3 or 6 months, change things if they don't want to go on a statin, and come back and they can chat about it. At the end of the day, it is, and Isabel, you're right, it's up to you whether you want to go on the medication or not. We can only give you the evidence as physicians, and then you decide what you wish to do. Okay. Okay, right. Angioplasty. So that's essentially where, well, it's like angiography, but angioplasty is where they put the guide wire up, put the dye through, they have a look, and then they can decide whether to put stents in or not. Those are the little coils that open up your artery again. And that can happen very quickly. That they can actually do that. They have what they call cath labs, catheter labs, where if you come in and you're actually having a heart attack, they can whip you away to one of the cath labs in your local area, hopefully, and they can put stents in straight away. Okay, that's one of they used to give clotting agents that would bust a clot very, very quickly. They can do that with strokes because they don't put stents in for ischemic strokes, but they used to do that for heart attacks. But I think first line treatment, if possible, is they will get you off to a cath lab and get a stent in if you're in the middle of having a heart attack. And then surgery obviously is an option if you're deemed to not be able to get stents put in for whatever reason. Okay. So just in summary, most of us will probably have fatty plaques, if not all of us, okay, in our arteries. We can, however, decrease the risk by changing our lifestyle. Okay. So eating a healthy, balanced diet, fats low or foods low in cholesterol. So again, if I chat to patients about this, it's usually I do one of two things. I chat to them about, well, saturated fats. So in the west of Scotland, I always refer to pies. Okay, pork pies, but pastries. I'm an absolute pastry lover, and I'm going on holidays. And when I go on holidays, it's usually the only time now that I'll have a croissant or something. Okay, but you know, I don't go on holidays that often, so I think I can have a croissant the odd time, but not very often. Physically active decreases your cholesterol, decreases your blood pressure, decreases your weight, works your heart and your lungs. Stopping smoking because it accelerates atherosclerosis. Okay, and then if you're a diabetic, controlling your blood glucose levels, that's really important as well. You're better your diabetes control, because if you're type 1 diabetes, you can't reverse that, obviously, but the better your blood glucose control is, you decrease your risk of heart disease. All diabetics, either who've had diabetes for more than 20 years, if you're a type 1, or if you're a type 2 diabetic, or you over the age of 40, automatically go on a statin because of the increased cardiovascular risk. Okay. Statins, however, can cause diabetes. Okay. There's something to throw into the mix. One of the guys I work with, Professor Satir, showed in a paper several years ago now that you can increase your risk of diabetes by going on a statin. Okay. The way I look at that is it doesn't move you from having normal glycemia. The chances are you're insulin resistant. You take a statin and it pushes you over the age to become diabetic. But as soon as you're diabetic, we're going to put you on a statin because you're increased risk. But we do know that really high doses of statins can increase your risk of diabetes. So we wouldn't put you on a high dose statin. And I think that's something we've learned. I think there's a new publication come out very, very recently about high dose statin, and that would be at 80 milligrams of atorvastatin. Okay. The other thing is, if you have a heart attack or a stroke tomorrow, up in my health board and definitely in Scotland, you will be put on a statin, no questions asked. All right. Because we know it does decrease cardiovascular risk, and we know lowering your LDL within the first year or 2 years of having an event decreases your risk of further events. Okay. Any other questions?
Nope.
No.
No.
Okie dokie. Right. So next week I need to explain, and hopefully anybody that's listening to the recording of this will also get this. I am on leave next week, but I'm somewhere that I'm going to Portugal, so the time zone is the same. So I'm going to try and do it on the Wednesday morning. but it depends on the IT. A little bit scary. No, I know, Elaine. I don't necessarily get the good session. I do all the medical stuff on a Wednesday morning. But the way I try and look at that is, if you know about it, you're more likely to be driven, I hope, to, you know, do something about it. It's like when I'm out walking every time, or I'm not out walking, as the case may be, and I know I've got about another 2,000 or 3,000 steps to do, and I kind of think, oh, and then I think, no, really, you know, I want to get up and walk because I need, you know, my heart needs to do something. And I also want to get some glucose into my cells, and I don't want to become insulin resistant. So that gets my bottom off the sofa and sets me out to go and do a walk. That's just the way my brain works. But yeah, it is quite scary. But what I find quite scary is the amount of patients that come into my clinic and have absolutely no idea. But the problem with them is I only have 9 minutes. I don't have an hour to sit and chat to them. Okay, Sarah, nice to have you along this morning. Yeah, so next week, what I'm trying to say is, hopefully, if it's not going to go ahead, if I'm having IT issues, I will hopefully have told the TSD admin people by Monday, Tuesday, and they will let you all know by email that there won't be a session next week. But there will definitely be one the week after, because I'm back in the UK. If it all goes pear-shaped, and I have said I'm having a session, but for whatever reason I can't get on the link, or you can't get on the link, or whatever, I'm just putting that out there. Don't panic. We will catch up the following week, but all being well, fingers crossed, I will be here next week. All right. Well, look, have a good week.
Caroline.
Have a lovely holiday.
Yes,
Keep walking.
enjoy.
Yeah, I'm going to get to do my press ups in the sun.
Right.
Yeah.
Which is good. Although I'll have I'm bringing my resistance bands with me. That's always a bit of a laugh, trying to do a workout with a set of resistance bands that I haven't done for ages. So the chances are I'll probably let one go or slap my face with one, but you know how it is. Right.
Enjoy.
Anyway, look, yeah, have a fantastic week, and I shall hopefully catch up with you next Wednesday. Okay.
Thank you very
Bye.
much. Very
Thank
interesting.
you. Bye.
Thanks.
Very interesting.